welcome everybody to this evening. We're going to be talking about anatomy of the midface and then some treatment techniques as well. And this will be covering some of the stuff that we've obviously learned in your mentoring, and also some stuff that you've probably picked up in your own private practice, and some other techniques as well, which I'm going to talk about as you become more advanced as an injector, some other things we can start to introduce. I think for me, the midface is probably one of the most important areas to consider for treatment. In my private practice, it makes up probably around 70% of my workload. And that's primarily because it's an area that for most of my patients gives them the biggest results and is often what they need the most, even though quite a lot of them don't necessarily present with that. With that main concern. So, if someone comes up, we've always talked about with nasolabial folds, you have marionettes, the midface is a really, really good place to start before we then start addressing filler directly into the folds. And I always like to explain that to a patient in the sense of you haven't actually lost volume in your nasolabial fold or your marionette area. Really, the volume's much higher up in the midface. By restoring that, we give you the most natural and the most beautiful result, really, when we do that. So I've muted you all at the moment, just for the background noise point of view. What we'll do is we'll do the slideshow first, and at the end what we'll do is go through and see what questions we've got on the chat box, if that's possible. This webinar will be recorded this evening, so it will be shared with you guys at a later stage once we've finished the presentation. So to start with, we're going to talk about what defines a midface. So where does it start and where does it end? If you give me 1 second there, perfect. So where does it start and where does it end? And this is just to sort of give you some idea of the boundaries, some of the landmarks that we see. And truly anatomically, this is what defines the midface. Fine, so this should be a little bit better now for you guys. So where does it start, where does it end? So essentially this defines the anatomical borders of the midface. So from the upper boundary point of view, you've got the superior helix of the ear, as you can see on the left side. The line goes along the top of the zygomatic arch and meets at the lateral canthus of the eye. From an inferior border point of view, you've got a line that extends from the inferior border of the tragal cartilage right to the oral commissure. And this is what we're going to be talking about today. This is the key areas which we're going to be talking about the relevant anatomy of, which will help you be able to understand why we treat the way we do, and also explain to your patients as well the way we're treating. So the facial skeleton starting right at the bottom. And for this presentation tonight, we are going to be talking about the different facial layers because it's really, really important in the midface. And truly, I think the midface is probably one of the most complex anatomical areas to understand in facial aesthetics. But once you do, it really changes the way that you practice. So from a skeletal point of view, essentially you're treating over the zygomatic bone and the maxillary bone, as you can see here on the pink and blue kind of areas. So this is more in relation to your superperiosteal boluses and some of the suture lines you might feel when you're doing that injection. You can see on here the foramen that line up, particularly the mental foramen, your infraorbital and your supraorbital notch or foramen. And those three foramen do line up in the face. And whenever we're doing any treatments, particularly mid-face, it's really, really important to draw on the face and start with some markings. It makes up, much more than half of my time with my patient is spent marking up because it's so important to get that right. Now, more important than anything when we're talking about treatments, and I can't stress this enough for the midface, it's really important to understand your 5 layers. And your 5 layers we'll be talking about tonight, depending what layer we're in, what kind of treatment we're offering, and why we're doing it in the way that we're doing it. So, starting with 1, you've obviously got the skin, so your epidermis, your dermis, and your hypodermis, which leads us on to superficial fat at layer 2. Now, the main feature really when we're doing treatments in this zone is layer 3, which is the division between the superficial fat compartments and the deep, so the SMAS, or the superficial muscular aponeurotic system. And this is a very thick, and you can see on this diagram actually where 3 and then that little white sheet above it is, which is the SMAS, is a thick fibromuscular layer that lines right from the neck up into the temples. It is the same layer that as a plastic surgeon, this would be the area that's tethered back to lift and restructure the face. It's also the same area, interestingly, when we talk about aesthetics and devices that are on offer, that ultrasound would work on. So when you're thinking about Ulthera, Ultherapy, those kind of devices, these are all targeting the SMAS. And the idea is to cause a contraction of this layer and hence a lift. So When we're doing treatments, we use the SMAS as a gauge to determine where we are in the skin. We can feel that when we're using something like a cannula in the midface, which I'll talk about later. So you've got your skin, your superficial fat, your SMAS, which is your dividing layer. Deeper to that, you've got your deep fat pads, and then onto periosteum as well. So your 5 layers, and it's really important to understand this. The SMAS also contains some of the muscles, so some of the muscles of expression, such as the orbicularis oris muscle and the orbicularis oculi as well, are slightly encapsulated in the SMAS too. And so when we start treating beneath the SMAS, the sub-SMAS type treatments, you get a lift that affects the whole face. Hence why if we treat in the temples, we can turn up the corner of the mouth because we're getting a lift that's below the SMAS onto bone and hence getting that upward traction from doing that. So the midface anatomically is quite odd. It's a structure that's unlike anything else in the face. So why is it different? Well, essentially, the soft tissue structures, such as the fat pads, have spaces underneath them, not solid structures. And the reason for this is quite interesting, because if you think about the midface and where it lies anatomically in the face, it actually gives rise to glide planes, because it's a very, very functional part of the face. If you think about it and you put your tongue right up into your top cavity of your mouth, you'll feel you're actually going under quite a bit of your midface by doing that. And these glide planes make the actual structure of the face interesting to treat from an anatomical point of view. So here's a picture that shows those compartments and sliding glide planes as well. So you can see here that you've got 3 key ones that you can see. So you start with the bottom one that's down on the teeth in the bottom of the diagram here, and that's the buccal cavity. So it's your mouth basically. And this compartment actually goes quite high up when you think about where actually it goes. And if you feel how far your mouth actually goes up, it is relatively far up into the midface. The next one's really interesting. Higher up. So the preceptoral is that one, but this one for me, the prezygomatic space, is a very interesting compartment in the face, and an area which we often treat if we're using cannula-based treatments in the midface. And the reason for that is it's an area that's actually boundaried off very, very well. So it's an area which you can compartmentalize product into, and that they will stay in that compartment without movement. All these structures we're talking about are sub-SMAS. So they're all in layer 4. They are not above the SMAS layer. And so to get into them, we will need to be penetrating through that SMAS, which is a technique which you will learn when we use a cannula. So what are the boundaries of the prezygomatic space? Because it is a space of particular interest when we're talking about cheek revolumization. So on the upper edge, and we'll talk about these in a minute, on the superior border, you've got the orbicularis retaining ligament. On the lower, which is that line that almost extends from where the tear trough is and cuts through the cheek, which you actually see anatomically in some patients, is the zygomatico-cutaneous ligament. On the anterior border, you've got the SMAS, because it's literally just below it. And then inferiorly, you've got the periosteal fat sitting on top of the bone. So for me, the prezygomatic space is an area of particular interest. It really helps shape mid-face treatments when you start using a mixture of needle and cannula techniques. So let's talk about fat compartments and different zones in the face. And these can be, I find these personally quite confusing, because actually when we start looking at superficial fat compartments with different textbooks, different people that sort of, you read different information about different things, they can be quite difficult to understand, because it's laid out in so many different ways. There's the malar fat pad, there's the medial fat pad, and exactly what are we talking about here? So when we start thinking about that, this diagram is quite useful. It's probably the most useful one that I've come across, which helped me understand it a little bit more easily. So essentially, the malar, this is all layer 2, by the way. So we're in the superficial fat pads here. This is layer 2. It's often not an area which we treat in the sense of deep tissue revolumization and lifting the rest of the facial structure up. But sometimes we do treat in this layer if we're trying to get that refinement. So particularly if we're trying to contour the face and we want a little bit more sharp edge on some of the elements, it's very useful to work in this space. So really, to simplify it, you've got from the right side of this picture, the lateral, the middle, and the medial fat pad, okay? And that's all the bluey and green ones in there. And they together make the malar fat pad. And that's probably the most confusing thing that I always found when I was doing this, is that they were all called so many different names. So you've got laterotemporal, your middle, and then your medial. And that kind of covers your superficial fat pads. More medially to that, you've got your nasolabial fat pad, which is of significant interest, purely because it's one of the fat pads that ages a little differently considering compared to the other ones. And then below that, you've got the jowl fat compartment as well. So this is layer 2. This is your layer 2 fat compartments. So if I show you what that actually looks like in more of a realistic, non-marked out way, you can see that actually it's very difficult to make them out anatomically. And the only way you really know when you're doing this and you're doing the treatments is you'll feel that resistance when you're working in a cannula in layer 2. And that's because you've got these fine septae that break up these fat pads. So going from the inside here, you've got your medial, your nasolabial even more medial, you've got your middle, and then you've got jowl fat, and then obviously your laterotemporal as well, which we just talked about at the beginning. So laterotemporal, middle, medial, they are all your malar fat pad. And this will be more clear on the next diagram here, which is one of our own. So this is quite interesting because this puts them all together. So again, if you remember, we're in layer 2 here in the superficial fat compartment, malar fat. Next to that is the nasolabial fat. And as you can see, as we age, we lose volume. And essentially, we lose volume in all of these fat compartments. This diagram is actually incorrect because actually the nasolabial fat pad is one of the only fat pads that increases with age. Instead of atrophying, it actually hypertrophies a little bit. So it actually gets a little larger. And it's particularly important to know this because when we're talking about doing treatments in that zone particularly, and we're trying to treat into the deep layers, you want to make sure you're in the right layer. You don't want to be in layer 2 when you're trying to be in layer 4, because layer 4 you lose a lot of volume. Layer 2 you're actually increasing in volume as we age. And by putting product into the wrong layer, you can get, well, essentially you can make someone's nasolabial fat pad much worse by filling in the wrong layer. So moving on to the deep fat pads, which are really the ones that have the most interest when we're talking about deep tissue revolumization. So these are in layer 4. We're now on top of periosteum and we are subsmass, we're below that. In the face, the main one and the really important one, which you'll start to notice on people after we spoke about this evening, is your deep medial cheek fat. This is the one that really changes as we age. It's the one that has the most significant atrophy and the one we really notice when we're looking at people. And also it's the one we can do the most good with. However, it's also one that's quite challenging to treat, particularly with a needle-based technique. You can't really treat it with a needle. We would advise always using a cannula in this medial of the face because you're working over and around the infraorbital foramen. So the deep medial cheek fat is the one that really loses the most as we age. We've also got other things you can see that start to happen. So you've got bony absorption, so you've got loss of that, increase in orbit size, loss of maxillary angle, and all those things contribute to the effects that we start seeing. One of the things when we start thinking about lower face, and I know we're not talking about it in particular tonight, is that when we get these mid-face bony losses, we also get loss of the mandible and the chin starts to recede. And as that happens, we almost get a folding over of the mid-face over the lower face, hence giving rise to our nasolabials, our marionettes, and the start of our jowls. So when we start to think about aging like this, and when your patient comes to you and says, look, I want my nasolabial fat pad filled, or my nasolabial fold filled, it's our job to educate them to make them understand that the reason they've aged is not because they've lost volume in their nasolabial fold or their marionette fold. It's because they've lost volume at a much deeper plane to that. And if you simply start filling folds, what you'll find is that the patient will look like they've had filler because they'll still have all the causes of their problems. You've just addressed the signs and the symptoms. And it can make someone look quite strange if you do that. So really by addressing the mid-face first, and particularly your deep fat pads, is often the most effective way to treat someone naturally and also give them a result that lasts a long time as well. So I wanted to show you a diagram of one of my patients actually, and some of you actually might recognize her because she works for a big skincare brand. But essentially she's given me permission to use these photos for our learning. So here what you've got is a picture of a patient with the deep fat pad. So here we've got your deep medial, you can see on the left picture nearest the nose. You've got your buccal fat pad just to the right of that, and those ones above it are representative of the SOOF, which lies just below the eye, and it's one of the areas we'd often treat if we're doing tear trough. And this is broken into the medial SOOF and the lateral SOOF here. So as you can see as we age, what happens? Well, both those fat pads, particularly the deep medial, really, really shrink. And with that, you get this vertical descent, which contributes to your nasolabial. You can see here, you've got the marionette formation, the start of that jowl, and this happens to everyone as they age. And it's a really useful thing to explain to your patient when they're coming to see you. This is why you're aging in the way that you are, and this is going to lead on to why we're going to treat the way we do. So the other thing I think is important is ligaments of the face. It's something that's not necessarily spoken about too much, but I think it is important, particularly in the midface, because it gives rise to surface landmarks that often bother patients. And the difference between true and false ligaments in the face are true ligaments run right from skin all the way to bone. So they run the whole 5 layers, whereas false will connect different layers together. So true ligaments are the most relevant for our patients because they're the ones they start to see as gravity starts sagging and we start losing volume in those areas. And I'm going to show you a photo of that and demonstrate that for you in a minute. And true ligaments are the ones, so I say here, true ligaments tether periosteum to dermis and false ligaments tether intervening facial tissue layers to each other. So when we start thinking about those ones I spoke about earlier, your zygomatic cutaneous, your orbicularis retaining, they're both true ligaments. So you actually see them on the surface. And this is another diagram that I drew just to kind of demonstrate what that looks like and which ones to look out for. So on this, I'm going to talk to you about what we've got here with a few labels. So you've got your orbicularis retaining ligament, which, to be honest, we don't get involved in. We never go past it. Even with teardrop, we're treating just below it into the SOOF. We've got the zygomatico-cutaneous ligament, which is this one that comes across. And this is the one that a lot of my patients come to me with and say, look, this is the indentation across my cheek. I've noticed it's extended from my eye and now almost breaks my cheek into 2 separate compartments. So this is a really important one, your zygomatico-cutaneous. The next one here, as you can see, the fat pad there is the SOOF. We've got the prezygomatic space as this blue sort of space that, as I described earlier, is compartmentalized by your orbicularis retaining and your zygomatic cutaneous. So it's a great space to put product into because it can't go anywhere or migrate. The next one there is a deep medial fat pad and then the nasolabial. And to be honest with this diagram, when we look at it, if we imagine where the SMAS is, the SMAS would cover the whole of this diagram apart from the nasolabial fat pad, which is in layer 2. So I hope you guys are getting a better understanding of the layers and how they're relevant for the anatomy we're talking about. So here we're looking at it, we've got layer 2 nasolabial, SMAS covering all of those structures with those ligaments running right through it. And then we've got deep to that, your deep medial fat pad, your SOOF, your prezygomatic space. Another diagram of one of ours just to show you what that would look like. So you've got some of the retaining ligaments that you can see there as well. Now, what does this look like in practice? What do patients look like when they come to you with this issue? Well, this is a really nice example. So this young lady, you can really make out the zygomatic cutaneous ligament on this lady as a surface landmark. And like I say, it's one of those areas that I get relatively frequently people coming to me saying, you know, this is an area of concern for me. I don't like the way this line falls across my cheek. So it almost makes, as you can see here, you've got the change between the medial cheek and the lateral cheek, and with that you can really make out on this picture where the deep medial fat pad has lost volume from. When we revolumize that, what does it look like? Well, we can help disguise that line significantly only if we're treating both parts of the midface. So we're treating the medial side and we're also treating the lateral side along the zygoma. And with that, you can see great result, lifted the nasolabial fold, but still looks very, very natural. And you'll actually find some young patients will have some element of volume loss in the deep medial fat pad, even at quite an early age. So you're talking really from the age of the mid-20s upwards, we do start seeing volume atrophy in this area. So it's an area actually, if a young patient comes to you and is concerned about, you know, indentations such as this zygomatic cutaneous ligament surface landmark, you can place a small amount of product in the deep medial fat pad and it gives a brilliant result that still looks really, really natural. So that is the superficial fat pads and the deep fat pads of the face and what they look like. And I think from a treatment point of view, they're probably the most important because they're the ones that really determine the way we do treat. And I have a video actually, which I'll show you at the end of this presentation after we've talked about techniques and things of a patient being treated using a cannula technique for the midface, which addresses both of those areas. So moving on to vasculature, because this is obviously when we start out as an injector, it's an area that's very worrying. We want to make sure we're safe. And when we're treating the midface, we generally are. We're working around areas that are relatively avascular from big vessels. And so as long as we know that and we're marking out on the patient where we're going, it's a really safe area to treat, even with a sharp needle. The only place I would really avoid a sharp needle, as you guys have all learned, is medial of the midpupillary line, okay? So anywhere when you start getting quite medial with a sharp needle in the zygoma towards the infraorbital foramen, you want to be really careful with that. And that's why often for a cannula for this kind of treatment is where you should go next. And really to complete the cheek treatment, you do need to address both of those areas, in my opinion. So the face is supplied by the external, the branch of the carotid, the external carotid that goes up and supplies the face. The facial artery is the main vessel that does that. But in the midface, it's relatively important because we also have a branch called the transverse facial, which quite scarily, when we first start looking at it, runs across the zygoma. And actually, if you palpate quite lightly on your lateral zygoma, you may feel a pulse. Okay. So another diagram that just shows the course of the facial artery. So emerges over the mandible at the anterior border of the mastus. If you clench your teeth, you can make that out on your jawline. Runs quite a tortuous course up past the lips, branches off to become the inferior labial, superior labial, goes right up to the corner of the nose, and then goes up as an angular artery. Now, just out of interest, when we're talking about layers and vasculature, it's really important to know as well with our 5 layers, where does our blood vessels lie? So when it comes up over the mandible at the anterior border of the masseter, it's deep. We're talking layer 4, we're layer 4, layer 5 at this step. So we're really on bone when the vessel's running around here. So for example, jawline treatments in layer 2 with a cannula, we're safe. As it comes up and comes to the corner of the mouth, it actually emerges through the SMAS and becomes much, much, much more superficial into layer 2 in quite a few individuals. And this is why we always say for nasolabial folds, using a needle is not safe. You really want to be using a cannula in the nasolabial fold if you can, even though, for a long time we've used a needle here. A cannula is a much safer way to treat this area because it's much safer to do so, purely because we know that the vessel comes deep, layer 4 up to the corner of the mouth, emerges out over the SMAS, and then runs very superficially up as the angular artery and up into the forehead. So really, knowing which layer the vessels run is quite important. Transverse facial artery here you can see branching off and coming around the face there on the zygoma. And here's a really nice picture as well, just to show some vasculature. And people ask me, where do I get these photos from like this? So this is from a textbook called Face, a pictorial atlas. And although it doesn't have very much descriptive information in it, it's got amazing diagrams and drawings, which help us when you're looking at anatomy and to understand what and why we're treating the way we are. So as you can see, when we look at the zygoma itself, you've got a really nice depiction there of the infraorbital foramen and the vessels that come out of there. You've got the very small transverse facial artery on here as well, the zygomaticofacial artery that emerges from the zygomaticofacial foramen and then works its way across the zygoma. But really, from a main vessel point of view, we are safe when we're injecting in this zone. So we're going to move on to treatment now, and different treatment techniques that we can use for the midface particularly. And I'm going to talk to you about some of the standardized techniques and also some of the different techniques that some of you guys ask quite a lot of questions about. So when you get more experience and you're used to injecting, you can alternate your technique. And with different patients, I will use a whole different range of techniques. For quite a lot of my patients, I will just use a cannula technique for midface if they can tolerate it. I may use a little bit of needle work, a little bit of cannula work, and it really is as you get used to injecting, you become quite artistic in what suits patients depending on what their main concern is for you, and you understand what will be able to deliver the best result for them. So this is a picture I wanted to show you of one of my patients that again is consented for use. As you can see, I did blur out the eyes. However, she did let me know that everyone still knew who she was, so it wasn't that useful when I did that. But I think what's interesting here is this lady, she was in her late 30s. She came to me. Her main concern was, as you can see on the picture on the left, she had the way you can see that zygomatic cutaneous ligament dissecting the cheeks. You can make out the medial and the lateral parts of the cheeks on this picture on the left. And her concern was, look, my nasolabial folds are quite deep. They're really bothering me. I feel like I've got downturning of the mouth. My whole lower face feels shadowed. Now, she has had her lips done before. She's had numerous different treatments done, but actually for this treatment and this before and after, this was straight after treatment using a mil of filler in each midface. We didn't put any filler in her nasolabial folds or marionettes or anywhere. It was simply placed into the prezygomatic space and the deep medial fat pad of the face. And as you can see, an amazing result, very, very good. I keep this one because this is great to show my patients when they come in and are wondering about treatment. But this is, this is the kind of result you can achieve using just mid-face filler, and you can really get that great lift through the lower face as well. So this is another picture just from the side, and on the left you can see she's quite young, so she doesn't really have too much of a demarcation of a surface landmark point of view as zygomatic or cutaneous, but she still has it there a little bit, and it was the start of the aging process. We simply recontoured her cheek, for that effect. So when someone comes to see you, how are we going to start thinking about treatment? What are we going to start doing? Well, a full face examination prior to treatment is key. And this is really, really important. To have a look at somebody, get them under good lighting, give them a mirror, stand them up against a good background. That's where you're going to take your photos from. But it's also important when you're assessing them to do it like this, because it allows you to point out to them where their elements of volume loss are. I usually draw on the patient at this point and show them this is kind of where I would like to put a small amount of product, here. But also it allows them to have a really good look at their face, because people will come to you, and if you don't do that and don't point out to them what their features are before treatment, they will think you've done something to them, like, look, I'm asymmetrical now, when actually they were very asymmetrical before, and you just scaled things up for them. So it's a useful exercise to do, not least because you can help plan your treatment, but also it can help educate your patient and show them kind of what they look like before treatment, because not many people do look at themselves in the way that you will when you are going to do treatment. So have a look at the symmetry of them. Have a look at the proportions. How does their facial thirds line up? Is this patient going to be a good candidate for mid-face treatment at all? Where is their main concerns? Look at their facial shape, which we'll talk about in a minute. Look for volume loss, for folds, for lines. So when we start looking at the face as a whole, we can really start to appreciate what we're trying to achieve. And patients will come and say, look, the usual nasolabial fold marionette jowl, these bother me, I want some filler in them. I say, no, let's do mid-face. And they will come around to the idea when I explain it like this. But what I'll say to them is, look, we're not just helping lift the face from a fold point of view, we're also reshaping your face and giving you back that inverted triangle look, particularly for a female, obviously we're talking about here. So actually recontouring and giving the person cheek structure back, you actually change their facial shape. So from a distance, they immediately look more attractive, more refreshed, more well-rested, those sorts of things. From a male point of view, obviously we're looking for something slightly different. So from a male point of view, we want our bigonal distance, the angle of our jawline between that distance, to be the same as our bizygomatic distance. So it wants to be a square we're trying to create here. And we're not going to talk about chin and jawline for this, but essentially your jawline wants to be a straight line between the angle of your jaw and your most projection point of your cheek. A woman, you really don't want that. That's really, really not great. And actually what we're seeing quite a lot of recently with the massive kind of boom in jawline fillers is a lot of women being made to look like men, because we're simply making the jawline so defined and so big that they almost over project from the cheeks, which is not a good look. So for a female, we want a heart-shaped profile, really is what we're looking for. And for that, what we want to do is create that beautiful projection in the mid-face, sweeping down to a pointed chin. And by doing mid-face filler, we're lifting your folds, but we're also helping, get to that point as well. So what is the ideal mid-face? What do patients want? I think when you're first starting out and you're experimenting with mid-face treatments, it's useful to start with a female face, because it's where most of your patients will be, what you'll be treating. It's probably what you've trained most on. The male face is a bit more challenging. I know when I first treated my first few male patients for mid-face, it was quite scary, because you hear a lot of horror stories about feminizing the face, and you want to be careful when you do that, because it is quite easy to do if you just apply the same technique. And we're going to talk about the slight differences that you can think about for the male face. But when you're starting out, I think so much of the industry trains us in the female face and female beautification, that actually starting with that makes more sense until you've got your skill set up to be able to then start treating men effectively. So for men, you've got a flatter, more angular face. You've got uniform distribution of subcutaneous fat. And the apex of the cheek is lower, it's more medial, and it's more subtly defined. We don't want that apple cheek that we want in a female. So with a female face, it's rounder and fuller. We've got thicker subcutaneous fat in certain areas, and the apex is slightly higher. We want those high cheekbones to be able to do that. And you want that definition of a sweeping contour of the cheek too. So these are the differences in fat distribution, really, when we're talking about where the fat is. So the fat in men is much more widespread, it's much thinner, but it's more uniform. In females, it's more pronounced. So this is kind of what we want to replace when we're doing volume restoration. So this is a good diagram just to show you midface surface anatomy. So you've got your medial zygomatic arch, your lateral zygomatic arch, your submalar region, which you never want to be using a needle in because there's no bone really to inject into. We're kind of going more in these layer 2 here. And then your anteromedial cheek, which is kind of pressing onto your deep medial fat pad here. So cannula versus needle. I know so far in this talk this evening, I've talked quite a lot about both different modalities and how we sometimes use one over the other depending. I think when we're talking about, when we're first starting, we learn the 3 classical points of supraperiosteal boluses along the zygomatic bone. They work brilliantly well. It gives you that an excellent lateral structure and lift. And for a lot of people, it can be enough. I think when you're first starting out, we all learn with needles. I would advise you though to really, up your skill set. Trying to get a grip for the cannula makes a huge difference. More than half is probably of my work is cannula based. So I use a real split between the two, depending on what we're doing. But I think needles to start with are easier, less fiddly, but try and get used to using a cannula because it makes a big difference. And particularly for some of the mid-face work, to really create those results, like I showed you on the first lady, that on this sort of section, you need to be using a cannula. You're just not going to be able to do it with needle alone. Cannulas give the best result when trying to contour the midface in layer 4 and also adding volume to submalar region layer 2, so they're kind of towards a preauricular fat pad area. Now, you can contour in layer 4. You can also contour in layer 2 if you wanted to with a very soft product. They work very well here. When we're talking about this, it's almost pre-zygomatic space. But I would also say you need to be, like it says the next one, use a cannula only if treating the anteromedial cheek. And this is your deep medial fat pad. It's got to be cannula every single time. Never put a needle into your deep medial fat pad because you just don't know where you are. And you've got your angular artery under there, your infraorbital foramen and vascular bundle. So it really is the best advice would be use a cannula. Now, for those that use cannulas, great. If you don't, I think really you want to be using a 25 gauge or a 22 gauge. That's because anything smaller than that, so higher the number, thinner the gauge, thinner the needle, basically, or cannula, becomes quite sharp and can act like a needle. And there has been cases of people having intravascular injury with a cannula. And if you do, it's a lot worse than a needle because you essentially are cannulating a vessel, which is what they're designed to do. But we really don't want that to happen. So my favorite is a 25 gauge 50 millimeter TSK steroidlide. And that's what I use for most of my work. Sometimes you can use a 38 mil cannula of a 25G, and that's also quite good. But 25 gauge 50 mil allows me to work full face really. I think 22 gauge, I do use it sometimes, but it's quite large, and particularly the introducer is very large for this. So it can be a little bit more painful, but sure, 22 gauge is even safer. It's another safe option to use. So treating the midface, what products are we going to use? And this is another question we get asked a lot. What products are we going to use and why are we using them? So I've included a few of the ranges here so you can have a see for some of the products that you are probably using. You need a really high G prime product. And to be honest, when we're treating subsmass, so keep going back to the layers in layer 4 to layer 5, you can get away with using as thick as you want, almost the thickest products in the industry. And that's because you can give that really deep projection without seeing the product. It's why it's particularly important to know your depth. You don't want to be placing these products in layer 2. They've got to be subsmass. They've got to be in layer 4 to be able to give you the deep products to not be able to see them. So Bellaterra wise, that would be volume. If you're talking Teosil, Teoxane, you've got your ultra deeps and your RHA4. For Teoxane, what they would always recommend is a sandwich technique. So they would say use ultra deep down on periosteum and RHA4 more versatile in some of the higher layers, even in layer 2 actually with RHA4 you can get away with. But ultra deep works beautifully in the deep fat pads particularly. And if you do a full face with if you do like a mil in each side of ultra deep, that was the first lady I showed you actually, she had ultra deep. It's quite a punchy result, but a very good one. If patients want that hard projection that lasts, a year long, ultra deep's a great choice. RHA4 is beautifully moldable when you're first starting out. It's a much easier product to work with. Juvederm wise, you've got Voluma. You've also got Volux as a slightly thicker hygiene prime product, but at the moment that's only licensed for use in the jawline and chin. So Voluma would be the product of choice in this area, and that again is a great product because it can be used deep, but it can also be used superficial. And as a lot of you will know, the Voluma products last a long time, the Juvederm products. I think that covers probably most of the brands that you guys are using currently, but do ask me at the end if you've got any questions about anything else at all. So pre-treatment marking, how do we mark it out? This will be something you guys are very well used to doing. I still draw these lines on every single time, just helps me know where I am, and just particularly important is to get symmetry. So the first line is from the base of the nasal alar to the tragus. The other one is from the lateral canthus to the auriculomotor. This gives you your apex, which is where you want to place in a female the maximal projection. Okay, so that's where you want your maximal projection. And that is usually, if you're doing a supraperiosteal bolus, your most medial point would be that apex. As you can see on here, you're away from the midpupillary line, so we know we're in a safe zone when we're doing that. So treatment-wise, supraperiosteal bolus is long as diagmatic bone. You're layer 5, you want a periosteum, you're touching bone, you're aspirating, and then you're slowly injecting boluses. And when we're starting out with that, you can see recommended products here, your volume, your ultra deep, or your voluma. You can use RHA4 in this if you wanted to. Instead of ultra deep, it's a bit harder in very thin patients. So I think when we're doing this, what's a recommended sort of how much would you put in? Well, for this patient, for example, if you're using 1 mil, let's say, which when you're starting out, maybe you'll just do 1 mil, half on each side. You can get 0.2 on the medial side, 0.2 in the middle, and then a 0.1. And that'll give you a half mil in one side. As you get used to treating the midface, you pretty standard to say, look, you're going to need at least 1 mil in each side. So at least a 2 mil treatment just to get going. People can have more, but I find 1 mil in each side is usually enough to get a pretty good result that lasts a good amount of time, which still looks very natural. So cannula-wise, how do we treat cannula with a cannula? So I'm going to show you some of this at the end of the video that I've done myself, but this is one of the techniques you can do. So you can go in at the apex. So you want to be going to layer 4. And for this, you can use similar products as you would before. You're essentially making a small scratch in the surface of the skin with the introducer. You're then using the cannula to go into layer 2 to start with, so you can see the outline of the cannula. You're lifting up the cheek and then proceeding to push a little bit further down towards bone until you feel a pop. And that pop is you going through the SMAS. And once you pop through, you'll be in a very loose slide plane, which will be the pre-zygomatic space in this case. And that's where you can deposit product, which is very well contained. And you know you're deep enough because you felt yourself go through the SMAS. So it's very, very tactile when we're using a cannula in the midface because we're really feeling for that pop. And when we get used to knowing that and where we are, it helps treat the other areas we're going to be doing. So this is a cannula treatment. This can be really nice to help recontour the cheekbone. The other option here is to go in laterally. So you go in at a lateral point in the cheek. Again, you're lifting the whole cheek up. You're going in with the cannula, feeling for that resistance and that pop, and then it becomes much easier to glide through. And if you try and raise a cannula at this point, you won't really be able to see it. You'll be able to maybe feel it, but you know you're deep because you can't see the outline of it. If you can see the whole outline of the cannula, you're in layer 2 and you need to start again and come out. Because if you do place these products, it's not going to do too much harm, to be honest, with volume, RHA4 or voluma. I think if it was ultra deep, it may be a different story. But generally, if you're placing these products into this layer 2, they just don't last very long. And I know from experience, if you do this for a patient, it looks amazing on the day. You can give someone a great contour in layer 2 with something like a volume, RHA4 or something. But actually what you'll find is the product will just disperse. It's non-compartmentalized. We saw the superficial fat pads. You essentially place them over the malar fat pads, and it's just going to all disperse away, and you're going to lose a result after a few weeks. So talking about the preauricular fat pad. So this is submalar. So this is below the cheekbone. And this is an area that people do lose volume from. It's an important area to think about, and it's a lot of people won't necessarily come to you with this issue. But if you look at your patients straight on, and you look at them and they've got, quite good going marionettes and nasal labels, but they've got quite good cheek volume, it's often because if you look down the side of their face and the submalar region in front of their ear on their cheek, they've got quite a decent hollowing. And that hollowing is what can be filled with a layer 2 treatment. So you must be in layer 2 at this treatment, layer 2. If you're not in layer 2, you're going to be going towards a parotid, and the patient will definitely let you know, because as soon as you touch that parotid sheath, it's very painful. So again, as you can see on here, you go in at the apex, or you can go a little bit lower. It doesn't really matter as long as your cannula length reaches to the back of the shadowing you're trying to reach, the hollowing. Pop in the cannula, push through into layer 2. You should be able to see the outline of the cannula in this space when you're doing this, and you can slowly do some retrograde threads in this zone. Now, a tip that I learned a while ago for this is when you first start doing this treatment, you might do 3 or 4 threads and you'll come out and you'll be like, oh God, they've got 3 or 4 lines in their cheek, you can actually see the product because you're in layer 2. So when you're starting off, use a forgiving product. When we're talking about Bellatera volume, great, pretty forgiving. Juvenile Voluma, pretty forgiving. RHA4 is maybe a little bit not so forgiving to start with. 3 would be preferable. But one of the biggest tips is actually go in and subsize this area first with the cannula. So going in all the way, coming right back out to nearly bringing the cannula out and going back in at a different angle, and break down all those small little fibers. And it can feel a bit uncomfortable for the patient. You can flush it with a little bit of filler as you do that, but breaking that area down and allowing it to be an open space means that when you do start then, after you've subsized it all, to start filling, it will fill so much more evenly. Afterwards, stand behind the patient, bit of gauze on the face, and just give them a good compression, and actually most of it will blend down. If you don't do that first, you'll end up with little lines in the face. And it's not a big worry, they will go down, but it gives a nice aesthetic result for the patient if when they leave, they've got no marks really, or no kind of bumps and lumps in the skin. So the next area is deep medial fat pad. Again, I'll show you a quick thing on this video, but deep medial fat pad, entry point is variable. You can go into the apex, but I'd usually go in a little bit further down than this. Again, you must be in layer 4. And remember, it's got to be a layer 4 treatment, because if you're not and you're above the SMAS in layer 2, you're simply going to make that nasolabial fat pad in layer 2 bigger, which is getting bigger anyway. You're going to make more weight there and make the nasolabial fold worse. So for this, small little pinpoint in the skin with the introducer, introduce a cannula, lift up the cheek, and then push down until you feel the pop. And when you pop, you're in the deep medial fat pad. Now, when you're in this zone, be very careful. Movements of the cannula are very small. You don't want to be irritating any of the nerves in this area. And then slowly do a small amount of antegrade and retrograde threading, very, very gently. It's quite advanced, this technique. And if you haven't done it as a supervised practice, I'd advise doing it as part of your mentoring, or coming to us and asking, look, can we do a one-to-one and kind of cover midface cannula work? Because it is important and it's quite a delicate area to treat. This may make the patient's top lip a little numb, so lidocaine the product in this compartment, but don't worry about that, it's absolutely normal. Again, product choice for this, you can get away with anything in this compartment. To be honest, the thicker the better, it will last longer and give people that projection that they want. So with the man, how is it different? The male face, how do we find it slightly different? Well, again, you can do supraperiosteal boluses along the zygoma. What I would probably say is start small. Use small little boluses along to start with to see how it looks before going all in. You're in layer 5. You just want to note that to keep the volume more inferior when compared to treating females, to give a more squared facial shape rather than a heart shape. So when we're doing this, the apex should be lower. So we want to make sure we're drawing our lines lower on the cheeks. We want to look at the patient and decide where that should sit when we look at them anatomically. You can use a cannula again at this, much to what I've already said already. For most of my male patients, the thing they lose the most is the deep medial fat pad, to be honest, and that apex point. Once you put that in, have a look and see what they look like. After that, you can then assess and see whether they need any more of that lateral projection or not. But work with them, get a mirror, do a bit of work, see where you've got to, and you can always add a little bit more in as you go. Treating younger patients. So younger patients are asking for treatments more and more. I think it's a difficult one. Personally, I don't treat that many clients that are young. I treat most of 40 to 60 kind of age group. But patients that are this young are often looking for the more augmented look. So they're looking for more about a contour and more about building cheekbones up. And the best way to achieve this, if I'm honest, is to use a cannula in layer 4 along the zygoma to do that and to give them that extra facial shape that they're after. Older patients, you're restoring fat pad loss. It's the most rewarding treatments, in my opinion, really. Midface in the older clients that haven't had work before, it works very, very well. Sometimes you need to sandwich the technique, like I explained, so you can work supraperiosteally and at deep fat pad layers as well. It helps a lot for visible lines and folds, and this result just gets better because the hyaluronic acid blends in with the tissues as you hydrate the area, so it actually looks a lot better after some time when we've done face filler. So other treatments that can indirectly help the midface. So there's a couple of other things that we can also consider when we're doing these kind of treatments. One of them is master muscle. So for some patients, have a look at them. Is it midface they really need, or is it because they've got a very strong master and they grind their teeth? Doing a bit of master Botox can make a big difference to help reshape the lower face and give more of a heart-shaped profile. Quite an easy to do treatment. But if you're not sure about it, please come in and, you know, have a word with us about it. Ask about it on your mentoring. We can talk about it. You can ask me if you want. It's just Marcus at Harley Academy. We can go through it with you. But it's a relatively easy treatment to do once you get your confidence to do master Botox. The other option is to treat the piriform fossa with supraosteal boluses, which can help lift nasolabial fold. Remember, this is a high-risk area. You are treating in and around and past the facial artery. So you must be on bone and you must stay on bone. I've seen people aspirate in this area and aspirate blood. So you must make sure that you stay on bone when you're treating this. It's relatively advanced to do. And if you're not confident, I would avoid doing that to start with. So another patient example that I've treated just to show you how natural and how good Midface filler can work, and how it can really help soften so many areas. You know, with a bit of hydration, you get a bit of under eye, you just get a more refreshed, more well-rested appearance. It doesn't help that I drew on those little black lines on the picture on the left, which kind of makes it look even better, but they are just pencil lines we've drawn on there. So you can see, you know, facial shape just looks a little bit better. I did put 0.2 mils in her chin as well during this treatment, just to repoint that chin, and as you can see, it just brings everything together a little nicer. So that's a mil of product each side using Juvederm products to get that result. I think it was Juvederm we're using there. So yeah, that's the patient which I showed you earlier, and the one actually I've got a little video of. Before we do any questions, what I'm going to do is I'm just going to show you that video. So this is the same patient, and this is some Midface, and I skipped a little bit of it, but I'll talk through kind of what we're doing when we do this. So this patient, as you can see on here, so we're going to go through and have a few look at her markings and different bits and bobs. And she didn't really need loads of work doing. It was just more of a refinement and just a bit of a refresh really on what she needed. So as you can see on here, let's play the video. So her concern was nasolabial fold, that downturning of the mouth, and then just a little bit of jowl formation. You know, she looks very well anyway, but we're looking for this small amount of projection, a little bit of a lift through here, but then also importantly as well, we need to make sure we're addressing the midface. So this is now patients fully marked up. And what we're doing now is we're going to start, this is a completely cannula-led technique. I believe actually this is TSL we use. So this was an RHA4-led treatment because we didn't need something too punchy like ultra deep. We wanted something a little bit more versatile in this patient. We didn't want to see too much product. We wanted a very soft lift. So this is introducing the cannula, so the small entry point we make with the introducer. And you can see we've drawn on there all the lines that we need and kind of marking out where we're going to be going. So made that little entry point there, which you can can't hardly really see. Introducing the cannula. Now, as you can see in a couple of things in this video, I've lifted the cheek up, and you can see the angle of that cannula. We're working it down, and so we are sub-SMAS, okay? So we are below the SMAS. We're in layer 4 when we're doing this treatment. So cannula completely inserted. Yeah, this is RHA4. And then we're just slowly laying some of that product into that cheek area there at the apex point. So I can feel my cannula tip just about at the apex, and I'm slowly laying some product down in that point there to be able to do that. So this is that patient that we just saw who had that result that you asked me about the masseters for. So small amount of product, a little bit of stinging for the patient, can feel a little bit of pressure. So I can just feel there where the product is kind of going just above my finger, and I can feel the projection that I'm kind of putting in there very, very slowly. And for this treatment, what we're doing is for RHA4, I'm going to use 0.5 mil. So I'm using 0.5 mils in this area in the prezygomatic space, essentially in layer 4. And you kind of see how that's just giving that little bit of a lift in that part of the cheek. Always watching the skin, make sure everything's fine. So come out now and have a look, and you can probably just make out that cheekbone looks a little bit more lifted now. It's a little bit sharper, and actually a nasolabial fold looks a little softer, a little bit more lifted on that side there, which is quite nice to see. So what we're going to do now is have a look at the deep medial fat pad. So on the medial side of that, we're going to then do a little bit of product there. But you can see we've just given that little bit of definition with the cannula there that helps us just lift up the face, but also give her a bit of a contour too. So now we're having a look at the deep medial fat pad, which we're going to be doing. So this is the introducer. So small little point in the skin, which we're making to start with. And if when you talk about cannula work, it wants to be very, very superficial. You're just breaking the skin essentially to do this kind of treatment. I've gone in at a point that I know I can get to where I need to get to from a deep medial point of view. And then what I'm going to do again is put the cannula tip into the hole and then lift up the skin. So I'm pulling the mass towards my cannula tip, so it allows me to be able to then just pop through it. And this is exactly where I'm pointing, which is the deep medial fat pad. So the thing is with this patient so far is, as you can see, doing the lateral aspect of the treatment, great. You know, it does its job, it does enough. But there's that small amount that frustrates you with the medial side. If I just feel there's a little bit less volume there. So I would just like to put a small amount there just to help lift it. So introduce the cannula. This is a 25 gauge 50 mil cannula, lifting up the skin and then slowly working. You can see almost where that pop goes through, that I know I'm in the right place. So I know where I am. I'm tapping on the skin just as a bit of distraction to take away from the small amount of sting you get with the lidocaine. That's Dan telling you she can't feel anything, which is great. So small amount of pressure there. And actually, you know, we put another 0.5 in this spot here. So we used a mil in this side of the face. And as you can see after treatment, not too many marks or anything. You could see those two cannula points where we've been in. And, you know, really nice result, very gentle, very natural, very subtle. But overall, you know, patient was really, really happy with that treatment in total. So let's just go back to our picture here of our patient. And see, and this is the treatment we've just done for her. So this was a middle each side of RHA4, really nice treatment, quite natural, but you probably wouldn't look at her and think she's had filler, but actually when you see the before and afters, you can really make out where the difference is. So thanks everyone for listening this evening. Feel free to ask any questions now. This is the question part of the talk. So if you've got any questions about what we've talked about tonight or anything, please let me know. Let me know how you found it this evening and whether you want more content like this and more of these evening kind of webinars, because I think they're quite a nice way to do it, really. I've had quite a few of you sign up for this event. So thank you, everybody. But in the meanwhile, if you have any questions, please drop them on the chat box and I will answer them as we go. So I'll be here if you want to ask any questions. Otherwise, thanks so much to you guys for listening this evening, and I'm sure I'll see you all quite soon. Okay, one question here. So for the mid-cheek cannula treatment, is it better to approach from lower down? Do you mean that if you mean the deep medial fat pad, essentially it's wherever you feel that you've got a cannula reach from. If you've got a 50 mil cannula, you can go from wherever, you know, you've got good reach. I think for me, it's not so, it doesn't particularly matter. I would go about probably mid nasolabial, if not lower nasolabial, just lateral to that, make a little point there. And just, as long as you know what layer you're in and you can pop through into the deep medial, that's fine. So Claire Healy, you placed 0.5 mils deep medial fat pad as a bolus. Bit of a bolus, bit of a little bit of antegrade and retrograde threading. So small amounts of movement. I'm talking about 5 mils of movement of the tip and just slowly just flushing a bit of product in, nice and slow. Always asking the patient how you're feeling, how you're getting on. And that's what I did there. But yeah, 0.5 mil in the deep medial fat pad, absolutely. So Saeed, are you still doing the master classes at HA, Midface master class? Yeah, so we do the master classes. What we also offer now is one-to-ones, which we find quite useful. So instead of that, you come along, bring a patient, we provide all the products and all the teaching, and basically get an hour to an hour and a half time with us doing stuff like this. So we've had a few up here. So my clinic's up in Nottinghamshire in Southwell, and we do one-to-one training slots up here. So if you're interested in doing that and going through what this looks like in real life, sure, bring someone along. We'll provide the products for you, and I'll teach you what we've just done tonight. I can do whatever you want. If you want to do all cannula, half needle, half cannula, it doesn't really matter to me, and we can do that.